Now we next invite Dr. Alex Huang, who will be talking about uveoscleral glaucoma surgery. It is back, the pearls and the mysteries.
Okay, thanks everyone for being here. Yeah, uveoscleral surgery is back, at least in the United States, what I'm referring to. We'll talk about pearls and mysteries, because I told you I like mysteries, and so there's mysteries here. Here are my financial disclosures. I actually have no disclosures for this particular talk, and my sources of research support as well. So I like to start with a little bit history first, right? What were the original observations that led you to think that there was even outflow? So this is, Lauber's dogs in the 1900s, where Lauber took the episcleral blood around the eye, and then he took the episcleral blood around the periphery of the dog. And what they found was that the hematocrit was lower in the blood around the eye, and that led to the idea that the eyeball was letting out a clear liquid to dilute the blood, so therefore, trabecular outflow, one of the first observations. What about uveoscleral outflow? So this is 1950s Anders Bill. So he would put in radioactivity into the eye and then collect the radioactivity out of the eye from the trabecular pathway. And he realized that every time he could never really get back what he put in. So there has to be a second door, and the door was big. So what he then ended up doing was sacrificing the animal, putting a piece of film on the tissue. The radioactivity would develop the film, and that's called autoradiography. And guess where he found the tracer? In the uvea and the sclera. Hence, uveoscleral outflow was a second door, the lost fraction. So why does this all matter? Well, thank you, Arthur, for setting this up already for all of us, at least with respect to trabecular MIGS. Once you put the Goldman equation up there, the idea is to make resistance zero, although we probably don't even really achieve that. But that is the goal, to lower the pressure. But as Arthur had mentioned, there are limits here for trabecular surgery because you're only going to get as low as EVP. While it's pretty good, we don't even quite get there. There's limits. From the uveoscleral side, then we have the modified Goldman equation, where your original F variable for, aqueous flow rate gets broken up into two pieces, including F out, which is uveoscleral outflow. Now, the thing to point out here is that F out has a negative symbol in front of it. So if you make that a really big number, it's a really big negative number, which can overcome all the other variables in the equation, and you can get a really low IOP, which you know from traumatic cyclodialysis clefts. That's why there's a lot of promise here. So let's remind ourselves a little bit about the pathways, because clearly uveoscleral outflow is not taught as well, right? At least it's in the name, it's in the uvea, it's in the sclera. Okay, we start in the anterior chamber. It's going through the ciliary body band on gonioscopy, so you actually are looking at the door. Then you have the ciliary body cleft, which is the key piece, right? Because we're very clear that trabecular meshwork is the key piece for trabecular outflow. So what is the key piece for uveoscleral outflow? It's the ciliary body cleft, going to the suprachoroidal space, and then there are multiple parallel pathways. So in the red arrow on the right, that's trabecular, number one. Number two, uveoscleral is the green arrow. That's where it starts. And the black arrows are pointing at the clefts. Let's talk about this a little bit more. So these clefts were noted for a long time, typically on histology 25 years ago here, right? These clefts, some people debated, were they artifacts of the histology or are they real? And so the idea is that these could be real because, as we know, when people get older and animals get older, uveoscleral outflow goes down. And then if the same sectioning is performed in an older animal or person, the clefts go away. So this is kind of circumstantial, but the idea is that the clefts are very important to uveoscleral outflow and something we need to maintain. So how can I prove it to you? I can punch you in the face, because I can give you a cleft. It's the same cleft. Ciliary body cleft here. Over here, it's called cyclodialysis cleft, right? It's an iatrogenic creation of the actual same thing. And you guys know pressure can be really, really, really low. The problem, of course, is I can't quite punch you the same way every time in every patient. So stereotyped. So we want a surgery to do that. And this is why there was the whole field of, uveoscleral MIGS coming along. There was the Solex Gold shunt on the left. It failed. It got too scarred up. Glauco started developing the iStent Supra, and then they stopped developing it, and nobody knows what happened. And then we have the CyPass on the right, which some of you may be familiar with. The CyPass was FDA approved in 2016 for lowering pressure. It's this implant that's stuck into the suprachoroidal space to create that cleft. IOP did drop. Patients got off their medicines a little bit, but okay, mystery number one. It's not that strong. It's like trabecular MIGS. I thought we were supposed to be dealing with hypotony here. Kind of weird. But we never really had the time to figure it out. Why? Because then it wasn't safe and the cornea was dying, and so then the product was pulled from the market. And I thought at this point that nothing would ever happen, and the whole space became radioactive. But at least there were still industry members that continue to push this space. So I give iStar a lot of credit as they continue to develop MiniJect. MiniJect is not available in the US, so I've never done it, but is available in other places in the world. It's another implant that can go into that space similar to CyPass, supposed to be safer. But yet again, if you look at the right, pressure's not that low. Yet, maybe in this surgeries, it should be lower. For my experience, the only thing that we have available right now is the ALAFlow. So this is an implant, but it's just a piece of sclera, just like the sclera that you put on the glaucoma tube, okay? The idea is that it's acting as a spacer and it's porous, so it can let fluid through. The surgery kind of looks like this. You have a spatula, you create a cyclodialysis cleft. Oh my gosh, it looks so scary the first time, but it's actually, pretty easy to make. And then you put the sclera in there, either one piece or two piece with a gap in between. And that seems pretty scary as well. What do the results look like? These are all results with only one single scleral piece. And it looks like MIGS data, trabecular MIGS, meaning mid-teens IOP, and you get off a drop or so. So again, we're back into that space. And why isn't this more powerful and simultaneously maybe a little more scary? These are just my experience. I only started doing this surgery for the last couple of months. This is an Asian man who came from New York, multiple surgeries, high pressures. He got cataract surgery, the pressure jumped, and so he didn't want the second eye done. Eventually, his vision was decreased, so we did the second eye cataract surgery, and I said, okay, why don't we do an ALAFlow at the same time? At least maybe your pressure won't jump. Pressure's doing okay. We got him off one drop. It's not a huge decline, but he wasn't that high to start with. I will say that, I did my first double piece surgery just a couple of weeks ago. You can see the two green arrows. If I put the slit beam on it, it turns to white. But you can see the little gap in the middle. At post-op week 1, this person's pressure is 5. I've heard from my fellows it's starting to move upward. So it is thought that, two pieces can be stronger. So then let's start talking about the mysteries then. We've already been hinting at it. Why are these surgeries not stronger and simultaneously more dangerous? We all know that a traumatic cleft can give you a really, really, really low number. Well, it may be that the outflow in the uveoscleral space is segmental. Many of you may have heard of me talking about this story for conventional outflow. This is now only being studied more recently. This is HUANG Gong's work from Boston. It is animal data, putting these microbeads in the eye, showing that at least for uveoscleral outflow, it's more on the bottom of the eye. So it may be that, depending on where you put the surgery, you may have a bigger effect all the way to hypotony. And since we're always placing it nasal, maybe that's part of the issue. Mystery number 2, and this is the one that's very interesting. Do you even need to be connected to the anterior chamber for this to work? So there are a couple of stories out there of CyPasses that were badly placed. They were placed so deep that the cleft was closed, yet IOP is still low. Really? I don't know. But then there's CiliaTech that's coming in Europe. CiliaTech is an implant that just goes into the suprachoroidal space ab externo. They claim no connection to the anterior chamber, and they claim it works. How? There's also on the bottom the hydrogel injection. This is from a friend of mine, Ross Ethier in Georgia. I trust Ross a lot. This is monkey data where he injects a hydrogel externally and creates an expanded suprachoroidal space. And Ross also says no connection to the anterior chamber, but pressure is down. Kind of weird, but it does remind us of the original data that the most important anatomical piece of uveoscleral outflow is the ciliary body cleft. However we make it, maybe it doesn't need to be connected. So in conclusion, uveoscleral MIGS are back. At least in the United States, we have ALAFlow. MiniJect has been around for a little while outside of the US. These surgeries are safe and effective, but it's kind of weird. Number 1, there's clearly IOP reduction left unachieved. Surgeries should be stronger. They should be riskier. There is something we don't understand. And so there's room to improve here. And I'm kind of glad we have the chance to study this now, unlike CyPass. And then number 4, is a connection to the anterior chamber even required? Somehow there are devices and thoughts out there that that's not necessary. And this is something we need to figure out as well. But overall, I think the good news is that we actually have tools again to be used in our patients that then we can use to try to figure out some of these mysteries. Because due to the modified Goldman equation, if this really works in terms of attacking the ciliary the uveoscleral outflow pathway, we could actually achieve very low pressures.
Thank you, Alex. Any questions? I think that was very interesting.
I was going to say Sanjay was the only one who's not allowed to ask questions.
So I have first of all, fabulous talk, and I have been there. We've done cyclodialysis, clefts, and all that stuff. But I'm wondering if the latter half of what you discussed, where there is no connection to the anterior chamber, could there be a possible mechanism by which the ciliary body actually is not producing enough aqueous to lower the pressure, rather than the outflow?
Totally. So what you're referring to is that, we have cases where we have, these shallow choroidals and the ciliary body's detached, and if the ciliary body's detached, it's not producing aqueous well, so therefore maybe IOP's down like an aqueous suppressant. A couple of responses. Number one, they're small devices. Really, just a couple of clock hours is enough? Okay, but maybe it is. Why? Because we typically say that, production is pretty stable. So even if you knocked out 20% in one quarter, like 2 clock hours, it's like, one drop. So the possibility exists. So I expected someone to ask that question. And so I was going to be like, what are you going to do about it with it, Arthur? There's only a couple places in the world that can actually do the experiment to actually figure it out. Is it uveoscleral or is it decreased production? So, Celia Tech's got to come to you guys. Or Ross.
So, there we go. Okay, so fantastic talk, Alex. Really interesting. I haven't done anything uveoscleral since IPAS, but I think one of the things that you've highlighted is the Goldman equation actually breaks down.
Fair enough.
In these situations, because you can't have true pressure-independent flow that is greater than the aqueous humor production. So the worst you can have is that first term being 0. You're still not going to be below EVP. So you shouldn't have hypotony. So when you have a cyclodialysis cleft, a traumatic cyclodialysis cleft, and you start to get those hypotony and maculopathy, you're probably developing another mechanism, another outflow pathway that is not pressure independent, and that allows you to get below EVP. So it's essentially like an internal trab.
Yeah, you're saying the equation falls apart, and I agree with you, but still the hypotony's there. So the controlled surgery should be able to mimic the trauma. Unless the other idea is that, are there a lot of people walking around with traumatic cyclodialysis cleft that really don't have low IOP, that we never diagnose because we never see? Maybe traumatic cyclodialysis clefts aren't that dangerous either.
So the other question to his continuation to what he's asking is, like, since the equation itself falls off, now whenever we do a MIGS also, we don't know what happens to the distal collector channels, and that over time, does the body adapt to that reduction in the pressure by decreased production, or is there fibrosis of the collector channels, or even fibrosis or scarring somewhere else? And that, because the equation is now completely gone, so is there something that happens in the rest of the quadrants that kind of defeats this purpose?
Well, I wouldn't say that the equation is completely gone. It's clearly just not explaining the whole thing, right? Because the thing is, you can still measure aqueous production in the setting of the surgery and get some insight there. And so, as Sanjay suggested, I think that's a good thing to do. It may help provide or inform what's going on. So, but ultimately, that experiment's got to get done. And there's actually very few people in the world, and I'm not one of them, who can do those experiments.
We were
Dr.
also
one question.
Yeah.
So,
Yeah, same thing as your tubes for the scleral patch graft.
So, Dr. Huang, my question is that creation of cyclodialysis cleft, so cyclodialysis cleft per se cause a lot of hypotony. So now we are seeing a lot of MIGS being done, and a couple of patients have been referred to us wherein because of post-MIGS, hypotony has developed, and on looking at the angle after, doing a good evaluation, the cyclodialysis clefts have been, maybe 0.5 to 1 mm. Still, that is causing a lot of hypotony. So how sure are we that these, whatever instants are coming, that they will not have,
Well, that's the mystery. I have done trabecular MIGS and inadvertently cause a cyclodialysis cleft that's tiny, and the pressure is crazy low. I've seen patients with trauma, and the pressure is crazy low. But you do all these surgeries, it's not crazy low. So that's the mystery. Even when I do the surgery, it's not crazy low. And so that's where there's something that has yet
So
to be
like,
understood.
do we have a long-term data for it?
Yeah,
Like
yeah,
how
yeah.
long?
Well,
what's
CyPass as
the-
well as, I mean, forget about Alaflow, but you had CyPass. They didn't have massive hypotony in years and years of studies with many, many surgeries performed. I mean, did you even have any? No, zero, yeah. It doesn't make sense. But there's also potential.
Alex, how much of the sclera is in the intracameral space, is in the
Oh, it's just
angle?
it's a little tip. The whole thing, I think it's 6 millimeters long. You
Yeah.
make the cleft, you put the visco cannula, you push, and inside your imagination is like, oh my gosh, there's a big hole. You shove it in there, and then you're just trying to tip it, so just a little bit is sticking out.
Like 1 millimeter or so?
Or zero. I mean,
So
I'm
and
pretty
the,
aggressive.
I believe the cyclopen is different from the spatula that you're putting the graft with. So how do you titrate your cyclodialysis cleft? Because
Oh, yeah,
because
yeah.
there's
So
no
you make a
titration.
couple of clock hours with your spatula. It's like you're
And
making
how
a
deep?
cleft.
How deep are you
Oh,
going?
not deep at all. And then what happens is you stick the visco cannula into the hole and you push, and then that should make everything in your imagination it's bigger, right? And then you stick the whole thing in.
Michael has a question.
Alex, can you tell me, and I'm sorry to ask a completely different question, where is the fluid actually going?
You mean in uveoscleral outflow?
Because
Okay.
in animal models, I get it, but humans, it seems a lot of it is transretinal. It's sort of sticking in your retina.
I mean, after you get to the suprachoroidal space, of course, then we're starting to invoke many models and many species, but there are many multiple pathways that people have described through the vortex veins, through the actual sclera itself, through maybe uveal lymphatics that are regionally located. And a lot of this data, I take it, you're right, comes from different species, right? And so if you were to say to me, can you tell me exactly what's happening in a person, it's a little harder because some of these experiments were invasive.
So I would like to add to it. We did a ICG angiography in one of the eyes with traumatic cyclodialysis with really low IOP before correcting the cyclodialysis, and we found a lot of lymphatics there. So I believe for these surgeries also, the IOP should go down with time as lymphatics develop. So that could be one of the main mechanisms for the uveoscleral outflow to take place.
Arthur, do you have anything to add to that?
Yeah, it's a great question, and I think the bottom line is we don't know exactly the pathway of uveoscleral flow, even 70 years after Anders Bill started looking at it. But there is data that shows that it goes through the sclera, and prostaglandins change scleral hydraulic conductivity, and that's one of the theories of why it actually helps to lower IOP.
That would be a surface area, so the larger the surface area you have, because sclera is relatively impermeable.
Right. But
Unless you think that uveoscleral outflow is segmental, according to some people, meaning there's some segmental biology going on.
Yes, but there is still, it's still an impermeable structure. That's why we have a
Oh,
Well,
it's not
it's not
impermeable. It's not impermeable.
impermeable. Yeah. So it's,
but it is relatively.
Really low impermeable. Yeah, it's not
Right.
very impermeable. Yeah,
Yeah.
yeah.
but it's remember, it's not a high fluid flow that we're dealing with either. It's so.
But it keeps your eye formed.
Yes, 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 yes,
There's
yes.
something wrong with that argument because otherwise the whole eye would be porous.
Right, but
I don't understand.
so one of the in terms of prostaglandins, one of the suggested mechanisms is that you can change the hydraulic conductivity of the sclera to lower it, so you actually get oozing through the sclera. But then where it goes after that is a little bit of a mystery.
It's subconch space, subconch lymphatics.
Yeah, and then there's the work of Elkeluch and Dracol
Yep.
showing that if you give the monkeys prostaglandins for a long period of time, you get
Cis. Or clefts, yeah.
endothelialized channels in the ciliary body, and that may be pathways for aqueous humor drainage.
Another question, Alex. Were there any cases of chronic hypotony? Like how many cases of
I mean,
not even
if you look at all the CyPass cases, like we'd have to go back and look at the study, but like we're talking about, CyPass was around for years, right? Your chronic hypotony is going to be like this. And for the Aloflow cases, it's much newer, so there doesn't as much data and as much time, and it's also like this, So again, that's the mystery. I mean, at the same time, first of all, I think someone used to say, if we're glaucoma specialists, we shouldn't be scared of low pressure, right? So we should have some lower numbers to maybe push a little scariness, and then we end up with something good, but it's not even quite achieving that yet.
Thank you so much.